Welcome back to the Movement Professional Podcast. So today I'm riding solo again today, and we're going to discuss ankle sprains. So I had a recent question from a friend of mine that just sprained his ankle playing basketball. So I figured that would be a good thing to make the topic on. So we'll share the screen again today. So if you're listening just via audio, I'll try to be as descriptive as possible. But if you can watch this on YouTube, I'm going to use the Essential Anatomy app again to just show some of the ligaments around the ankle and just discuss what the ankle is. So first we'll start with what are ankles. So there's three different type of ankle joints that we could discuss. One is the talocrural joint, which is the thing that we typically think of as the ankle, which is the articulation or joint made up of the mortise created by the tibia and fibula. So the two lower leg bones come together, create a bit of an arch, and then that arch, underneath that arch is the talus bone of the foot, and that makes what we typically think of as the ankle, and that's typically the ankle joint that gets sprained most frequently. But right below the talus on the foot is something called your subtalar joint, which is the joint made up of the talus bone and then the heel bone or the calcaneus right underneath it. There's certain ligaments that attach those two bones that can also get injured. And that also plays certainly a large role in how our foot functions, just appreciating that there is a difference between the joint of the subtalar and the joint of the talocrural. And then the other joint that's pretty common if you watch sports, especially in the NFL, is the tibiofibular or syndesmosis joint. This is the joint where the two lower leg bones come together, the tibia and the fibula. And it's a syndesmosis, which just means it's a more fibrous joint. It doesn't allow for as much movement as most of the joints that we talk about, which are synovial joints. There's not a synovial capsule or fluid, but there's ligaments that attach these two bones together. And when they get injured, that's what we usually think of as a high ankle sprain, which is usually a much more serious injury than the ankle sprains that are lower down in the talocrural or subtalar. Serious, it just takes longer to heal. And it's harder to actually get it to heal because it doesn't move as well from that area. So let's take a look at the anatomy app so that we can look at some of this anatomy. All right, so here we have the ankle. So first we'll look at the joint. So here is the tibia in green there, and then next to it is the fibula. So these two bones together create a little arch or a mortise, and then the talus bone right there fits in. So let's see if we can isolate that. All right, so there's your talus bone, and that's going to be what connects again with the fibula and the tibia there. So that'd be your talocrural joint, and then the talus right underneath it is the calcaneus. So the subtalar or the below the talus joint is the joint made up by these two bones. And then what you can see is these little pieces of soft tissue that connect bone to bone. These are ligaments. So any of these ligaments can get sprained. We'll talk specifically about the ones that are most commonly injured. But just as you see the connection of any ligament, it's really two bones together by this soft tissue. All right, so the most common ankle sprain is that of the anterior talofibular ligament. So that's this one right here in green. All right, and basically the ligaments are named after their attachments. So anterior means front, talo means talus, fibular means fibula. So it is the front ligament that attaches the talus to the fibula. That's the most commonly sprained ankle ligament that I know of, and it's usually happens with an inversion sprain. So you see this a lot in basketball or volleyball, where someone goes to jump up and they step on someone else's sneaker and the ankle rolls inward. Usually it's a plantar flexed ankle, so it's coming down, your toes trying to get to the ground, but instead it steps on a shoe and then it turns inward. And that will actually sprain the outside of the ankle. So this ligament is on the outside here. The fibula is on the outside. So if you just touch the outside of your ankle, the bony prominence that sticks out there, that is the fibula, the bottom of the fibula there. If we go to the other side, we have, I've learned as the deltoid ligament, but it's also called the medial ligament. And you have basically several ligaments that come together that make this really broad ligamentous structure that attach the tibia to the calcaneus, or the tibia to, in this case, the navicular. So you're basically just getting this ligamentous attachment on the inside of the ankle here. So this ligament, or this group of ligaments, is less often sprained because the ligaments are pretty robust here, and it's less often that the ankle will move in the opposite direction towards eversion, which creates the injury on this side. So my friend George, who was asking me the question about ankle sprains, he did have a anterior talofibular ligament injury. I think I was there when it happened. By seeing the mechanism of it, it was pretty clear to me that that's what happened, and that we were playing basketball. So again, that is the most common injury you're going to see in basketball. The really common injury that you hear of in football, just based on the trauma and sometimes the way the foot and ankle gets caught, is the high ankle sprain. And that has to do with more of these ligaments up in not in the talofibular region, but the tibiofibular. So here's the anterior tibiofibular. So it's just the tibia and the fibula being connected. This is a retinacula up here. Let me hide that. And we can see this joint. So where the tibia and the fibula come together, that creates a syndesmosis joint. So again, the difference there is just there's not a ton of movement there. It's not really meant to move all that much. And there's no synovial fluid or synovial capsule between these two. But when these ligaments get injured, it's hard for them to heal. So it tends to take a lot longer. So there's the one on the back side. Posterior means back, anterior means front, and they're just ligaments that connect those two areas. So that's going to be the ligaments involved in more of your high ankle sprains, if you hear that terminology. And so we sort of alluded to this, but what is a sprain? The sprain is just the terminology for the injury of a ligament. And what is a ligament? A ligament is the soft tissue that connects one bone to another. That's different than, say, a tendon, which connects muscle to bone. So if you hear the term sprain, ligaments are involved. If you hear the term strain, that is muscle or tendon being involved, just to help you differentiate. What gets sprained? We talked about that. I demonstrated that the anterior talofibular ligament is the most commonly injured ligament in the ankle, located on the outside, and it's injured by inverting or rolling the ankle inward, where the deltoid ligament is the opposite. It's on the inside, and it gets injured by everting the ankle. So when the ankle is turned more outward, and there's not as much motion going that way, so it's less likely to be injured, but it does get injured. And oftentimes the ligaments that are less likely to get injured, when they do get injured, it's usually a longer healing process. And then the tibiofibular ligaments make up the syndesmosis joint, and that would be your high ankle sprain when that gets injured. All right, so we'll talk about an acute injury versus a chronic injury. So a lot of times when you're going to see with sports, it's going to be an acute injury. So what do you do at that point when it just happened, a day or two afterwards? You're going to have to look at limiting weight bearing as needed. And I always say this, as needed. Sometimes you get a protocol for exactly what to do afterwards. I really think, with my experience, I had a lot of ankle injuries when I was playing basketball. It really does depend, not just on the state of how bad the ligament was injured, but just on how much the pain and the inflammatory process afterwards is getting in the way of your function. So you do want to let your pain be your guide, but in a very specific way. So letting pain be your guide does not mean grit and bear it and just tough it out. It also doesn't mean totally forget about it and totally avoid everything until a certain amount of time has passed. I would want to be looking at movement early on, but typically I'm going to do that with less weight bearing. So that could be just lying on my back, elevating the foot, and just trying to move the ankle in different directions very slowly, using small range of motion at first, and just try to find the onset of discomfort. That's going to be important as we talk about managing swelling, that we're not afraid to move the ankle, but we have a very cautious process for assessing when the onset of our discomfort is. One thing I think is very valuable is although we're limiting weight bearing, possibly putting a walking boot on, but even without the walking boot, if we can be in the comfort of our own home on a controlled surface using crutches or a cane or some type of support structure to offload our weight bearing, so that we could practice the gait cycle in a very slow and controlled manner, it keeps us in the game. It tends to improve the healing time, in my experience. And I'll put some videos in the show notes of how I break down the gait cycle and walking, and from slow to fast. But early on, just being able to offload the lower body with some type of upper body support. I use walking sticks or hiking sticks a lot, but if you're really in a bad way early on, you may need something a little bit more aggressive, like crutches or even a walker. And again, this isn't something you have to do out in the community, but doing in the comfort of your home or in a clinic, just to go through the process of walking while offloading the injured side, but trying to keep the rest of the body in the gait cycle as much as possible. In my experience, that tends to help the healing process quite a bit, or it allows you to get back to things quicker. And you're in a process of just assessing exactly where you are throughout the process, and you'll be surprised how quick you can get better, and you don't have to play a waiting game. Along with limiting weight bearing as needed to manage swelling. All right, we'll talk specifically about the difference between inflammation and swelling, but when you have an injury acutely, there's going to be, hopefully, an inflammatory process, because that is the body's natural immune process to start to heal that tissue that's been injured. Part of that inflammatory process is going to be swelling, but swelling and inflammation are not exactly the same thing. So to manage swelling, we want to compress the area to our tolerance based on, the pain. Compression can increase the pain, and if it increases the pain, it could actually create more of a threat response and kind of keep us in a healing process that we want to be moving through. So we just try to compress in a way that we're putting pressure more distal or distal to proximal, which means we're going to be a little bit tighter at the toes than we are at the lower leg. And that's just to create a motion from the foot more up into circulation, up towards the groin, up towards the heart, so we can get some of that fluid moving through circulation, so it's not just staying stagnant down in the ankle. We can use ACE bandages for that, floss bands, compression sleeves. There's a variety of things we can use. The idea would be to try to be a little bit tighter near the toes than the lower leg as much as possible. You can do that better with ACE bandages and floss bands, which are just basically like big rubber bands that we can tighten strategically where we want to. Compression sleeves or braces are a little harder to do that with. And then elevate, again, same idea of when we're compressing, we're trying to create a specific compression that moves fluid from south to north. Well, that's what we're trying to do with elevation. So we want our foot higher than our hip, higher than our heart, so we can get that circulation moving out of the ankle, or that fluid out of the ankle back into circulation as much as possible. And we want to move as tolerated. So movement also aids in this process of trying to pump fluid from one area and move it through the rest of the body. We do have to let pain be the guide. So it's thinking about movement as a very slow volume knob that we're trying to turn up based on what we're ready for, but staying curious even early on in the process of, so oftentimes ankle circles, ankle pumps, they can be really useful in getting some of this fluid to move, and that actually decreases pain because the fluid, along with the inflammation early on, creates a lot of pressure and heat in that area. But if we can move some of that fluid out of there, we decrease some of the pressure in the area, it can actually decrease the pain. We just have to make sure that we feel like we're in control of the movement we're doing and we feel safe with it. So that movement could be, again, early non-weight bearing motion while we're compressing and elevating at the same time. We can combine all three. And I'll put some videos in the show notes of how to go about doing that. And then we can also, again, look at just slowing down different weight bearing function while we're offloading our weight with canes and crutches, etc., but trying to put our bodies in the position that we would want to be in if we weren't injured, but we just offload the structure and try to work the rest of our body in a manner that allows circulation to flow, but not increase the pain or cause any more damage to the area. All right, so specifically the difference between inflammation and swelling. When we hear swelling, that's really just any abnormal enlargement of a body part, and it's typically because of a buildup of fluid in the area. There's two different types of swelling that you can see. Is edema is a buildup of fluid outside the joint. That's usually more of a chronic condition, not typically seen with an acute ankle injury. A fusion would be more of what you see with the acute ankle injury, which would be the buildup of fluid inside of the joint. Inflammation, though, is basically a whole process. It's an immune process that promotes the healing of injured tissue. So it's actually a very healthy and normal response, but it can be quite uncomfortable. And if it goes on much longer, it really does get in the way of our function. So the 5 signs of inflammation are that there'll be redness around the area, there'll be heat around the area, swelling is one of those signs, and pain certainly, and then loss of function. So you can imagine inflammation gets a bad rap because it really takes us out of the game for a while, but it's really an important part of an acute injury. We want to allow it to kind of run its course to a certain extent, but we can kind of aid it in its process to allow us to heal a little bit quicker. If we, don't allow the swelling to stay stagnant for too long, if we kind of test the waters and see what our body's ready for, oftentimes we aid the immune response by being an active participant in it. And swelling can be, and often is present, separate from the inflammatory process. And we'll certainly start to see this after the first couple days and maybe after the first couple of weeks of any type of acute injury, is we don't have as much pain anymore. The inflammatory process is starting to do its thing, is kind of work through its process a bit, but we're left with some swelling. And this is something that's important to keep an eye on, because we don't get that signal of pain that there's a problem anymore, but we might still have a lot of fluid. If we look down at the ankle, one side is quite a bit bigger than the other. And that now really needs to be an active process of working that fluid out of there, trying to improve circulation, also improve lymphatic flow. So there's several systems in our body that work, and they're aided by movement to get that fluid out of there. And as we limit our function, which we need to do early on, we're also going to limit the function of some of those systems. So it's important that we get back to activity as quick as we can in a safe manner to aid the systems to get that swelling out of there. Because if that swelling stays down there for a long period of time, our body starts to recognize it as normal, but it creates a lot of problems. Our ankle can't function as well. The muscles don't work as well. Everything's a little distended down there. So you can think of it like the muscle attachments are a little bit spread apart compared to where they normally were. And there's just not as easy a manner of creating force in the muscles in that area. And it could lead to more intermittent pain, less balance, less coordination in the area if we don't work that swelling out of there. So that's something that we have to keep an eye on, even when the pain is minimal. All right, so returning to function. So we'll just talk about a process that I tend to use when I'm looking at this. And again, this is sort of dependent on where you are from a timetable standpoint after the injury, but everybody's going to be really, really different depending on their function and depending on how much pain they're getting after the injury. So I didn't want to make this really specific as far as the timetable is concerned, but let pain be the guide. And that's what I would do as a therapist, is I'm going to be trying to see what someone can tolerate from a pain perspective, but I'm going to do that by having them move slow and even be in more static positions early on before you get people doing anything that's a little harder to control. So the first thing I want to look at is walking, and I want to try to return people to a more normalized gait as quickly as possible. All right, so I already talked about that. That could be day 1, that could be day 2, where we're offloading the area by using canes or some type of walking stick, but we're still trying to slowly move through the gait cycle to understand, what can be attained and what can't be attained. All right, so I'll do another slide about the specific gait positions we try to look at, but assessing gait is going to be one of the most important things to do early on and thoroughly throughout the process. And the gait cycle then carries into more dynamic function like lunging, going downstairs, and then eventually agility and running. So we're going to progress gait mechanics to eventually, as we're moving forward, we add some type of step down maneuver, which adds more challenge to the ankle, adds more challenge to the strength of the lower leg. We're going to take walking towards walking lunges, which basically just takes the gait cycle and then lowers our level down progressively more than, say, a step down would. And then we go into something like I like to call the split hinge. You can think of it as like a walking runner's pose if you do yoga, where you bow forward a little bit, the back leg is straight, and then the front leg comes more forward. And the idea here is we're lowering our level, but we're also progressively taking longer strides and still being able to control the landing of the longer strides as we move forward. So if we think about what walking is, it is basically traveling forward over a point of support. So walking, if we break it down and we do it slowly, the base walking would be a very small stride, really, because we want to always stay stacked over our body, our point of support as we're moving forward. If we do something like a step down, now we're going to be trying to still keep generally a stacked line, but we're going to bend the knee to lower our level a little bit. That allows us to stride out a little bit more, but a little bit more than we would with walking, but not as much as we would with, say, a walking lunge, which would be then the next stride out where we lower down to a knee. And then if we go to this split hinge, we take even a bigger stride. So we're kind of bowing forward a little bit and we're bringing our body weight forward, but with our other leg stretched back. And it just keeps us moving forward, but we're going through really the same process, but the challenge just becomes greater. So the reason I like to do this assessment, and I will certainly put a video of this in the show notes because I know this could be tricky with me just talking about it, but it is a progression of looking at being able to challenge walking and moving forward. And it really checks a lot of boxes for ankle function. Once we work on all of that going forward, we can also work on a similar process going laterally with side stepping and side lunging. All right, so specifically the walking positions that I want to look for are three things for my assessment. There's tons of ways you can look at walking. You can really break it down much deeper, but I like to keep it simple. Three things I look for is a heel strike position, a stance position, and a rollover position. The heel strike position would just be the initial contact that's made with the heel of the front leg when moving forward. Stance would be when you're in the single leg stance position, and this stance is going to be contingent on the head being stacked over the rib cage, over the pelvis, over the ankle. So you're making a straight line basically from the outside of the ankle through the ear. And then generally in that stance position, the non-weight bearing leg is going to have the foot in line with the other leg. So it'll be like the heel under the hip, makes sort of like a figure four position. And then rollover is when you shift your body weight forward to the front leg, you roll over through the back big toe. And that creates what's called a windlass mechanism, which creates some tension in the plantar fascia, and it gives the arch a little bit of stability as we roll through. So there's a lot of things that can be assessed just by looking at those three positions. How stacked is the body position? How much weight bearing can be tolerated in any of these positions? So again, we're moving very slow here. How much flow is there when transitioning from heel strike to stance to rollover? A lot of times what you'll see is the foot will go through the process, but the body won't come with it. And when we slow walking down for most people, it feels foreign. So it's not going to be the most fluid thing, but it's safe. As we slow it down, we can make it very static. We could just hold the positions. We can rock back and forth between the positions. And again, we can do this with more or less support depending on what pain is allowing us to do. But we get a lot of information and we get a lot of improvement just by trying to really break down walking. The common thread of all the positions in walking is that the body stays stacked, which again means the head over rib cage, over pelvis, over ankle, trying to find the straight line from ear down to ankle. So in heel strike, the back leg will be stacked and the front heel will be in contact with the ground a little bit in front, very light contact. So 99% of the weight's in the back leg. With stance, 100% of the weight is in the standing leg and the other leg is not on the ground at all. And then rollover, we've shifted our weight forward. So now the front leg is the stacked leg and we just have a rollover onto the ball of the big toe of the back foot. All right. And again, I'll put videos and pictures in the show notes of all this. Outside of just the positions that we see with walking, some foot positions that we can look at that can really help us get a little bit more detailed about where we're bearing weight and what we're trying to strengthen within the foot is we have the four corners of the foot position, which would be where we have equal pressure through the inner and outer corners of the ball of the foot and the heel. So if you think about the heel having two sides, inside and outside, and then the ball of the foot having inside and outside, trying to have equal pressure through all four corners. We'll call it the four corners position of the foot. The windlass or propulsive heel raise position would be, as we mentioned during that rollover, is just trying to get contact to the ball of the big toe. So think about doing a heel raise. You don't want to just lift the heels. You want to try to finish that position by getting to the ball of the big toe where we're dorsiflexing or hinging at the big toe, but we're creating contact heavy through the ball of the big toe. So trying to be there, that's going to move our weight more to the inside of the foot, but we have no contact with the heel. Then there's a toe gripping position where we're flexing the toes into the ground. And in this case, the toes are touching the ground, but the ball of the big toe is off the ground and the inner arch lifts. We have a toe point position where the ankle and toes are in a full plantar flex position. So this is typically just seen with ballerinas and gymnasts. So with ballerinas, they'll actually amazingly be able to balance on the point of their toe. Where gymnasts usually see this in when they're non-weight bearing in holding their body lines or their hollow positions, is that they have a toe point, which creates a nice tension throughout the body. The supinated position would be thinking about screwing the feet into the ground, and we're biasing the outer edge of the feet, the outer two corners, and then pronation would be when our feet fall in towards the inside and we create more pressure towards the inside. So it's important to bring these foot positions up because we have to have some type of standard for where we're starting, and we have to have some type of assessment to see what's the natural tendency for an individual before injury and certainly after injury and while somebody's recovering from injury. So the four corners position is something that I just like to teach early on because it's a nice balanced position. It's a good starting point that we can then move from. The windlass position, again, is going to be touched on if we break down the gait cycle, but the four corners position would tend to be the position that I want people to try to find when they're in that stacked position. So whatever foot is in stance, ideally we're trying to go for the four corners position as much as possible. And you see that'll be quite difficult for people. So, toe gripping, over supinating, over pronating, these will be biases that you see early on, which if we can move people more towards a four corners position from an overly supinated, overly pronated position, or toe gripping is quite common because it is sort of a protection mechanism to try not to put as much weight through the ground. But what it does is it sort of allows, there's a constant tension that's going through the ankle, through the undersurface of the foot, and there's oftentimes not an ability to relax the foot if toe gripping happens too frequently. So it's really good to appreciate the differences there, because that could be a huge part of early rehab, is just working on, letting go of some of these foot positions, finding some of these contact points with the ground. Tends to be very safe, and it builds on the function that we're going to be moving forward with. And all this can be done while working on the gait cycle at the same time. Moving forward with prior function, or returning to prior function. So after we look at the gait cycle, or you can say at the same time we're looking at the gait cycle, we can also be working on improving balance in a very functional way. So the way that I look at balance is that there's three strategies that we want to be able to go through. And these three strategies will really take us through any movement that we need to go through to get back to the highest level of function we need. One would be leaning, which is an ankle strategy. Two would be hinging, which would be moving from the hips and the trunk, or a hip strategy. And then three would be stepping, or a stepping strategy. So the way that we can look at this, it's one continuum. So leaning would be just shifting our weight solely within the feet and ankles without any motion occurring at the hips or trunk. So we can think of this as like we're standing and we're sort of planking back and forth. We're leaning backwards to our heels as far as we can without arching our back. We're shifting forward or leaning forward into the front of our feet as far as we can without our hips hinging. Once we run out of room with that ankle motion, that leaning, then so we don't have to fall over or we don't have to take a step, then we can bow, we can hinge. So if we're shifting forward or leaning forward into the front of our feet and we're about to fall, if we take a bow and we hinge, we send our butt back and our head forward. That'll allow us to keep moving forward without having to take a step. And then the same thing is true if we're going back, we feel like we're about to fall backwards. We can arch our back a little bit. We can even drive our knees forward. We're thinking, back bend territory, which is extending the hips, extending the lumbar spine. That gives us a little bit more excursion going backwards. Once we run out of room with our hinging strategies, then we have to take a step. So think of it as we lean forward as far as we can into the feet. We have to then bow. We keep feeling like we're moving forward. Eventually, we're going to have to take a step forward with our foot to catch ourselves so we don't fall on our face. And then the same thing is true going backwards. Same thing is also true going in any direction, going to the side. We would either side bend to the side. Once we run out of room, side going, shifting our feet to the side. And then eventually we would just take a side step. So what these balance strategies allow us to do is one, that we build our excursion of not falling over, which is really important at all points of life. But this becomes a very slow to fast process. So our lean going right into a quick hip hinge might look something like a kettlebell swing, or it can actually look like a vertical jump and how we might land to catch ourselves and control our landing. If we jump up and we want to land well and share the load, we want to get our hips back and our head forward, and we want to be able to do that and react to it. All right. So when the ankle is recovering, we don't necessarily need to get off the ground. We don't have to deal with that landing, but we can work on the shifting within the feet. We can work on progressively trying to catch our balance by getting our hips back, and then eventually take bigger steps in different directions to catch our balance to see how we do with landing. So I think as we start to step in multiple directions, that's really the first introduction to landing. A small step is a small landing. A bigger step, we have to go with that step, bring our body with the leg, but there's also going to be more ground reaction that we have to deal with the bigger the step gets. All right. So to me, that's a really, really important process to go through, and to think of it as this gradual continuum of leaning to hinging to stepping. It really checks a lot of boxes of what we'll need to have our ankles and the whole body be able to react in a way that doesn't overload the area that's injured. Further progressing to prior levels of function, we look at running, cutting, and landing. So in the difference here between what we were talking about with balance or with walking and running, cutting, and landing is there is now more of the eccentric component, really the ground reaction force that we have to deal with. So that's going to be a little later in the recovery process. And, you know, that doesn't necessarily mean weeks later. That could be all within a couple of sessions that we see people are tolerating walking well. They're tolerating the balance, shifting, hinging, and stepping well. And then we start to get the feet off the ground and land. And we do that in a very progressive way. So usually I'll start with step ups or box jumps as a starting point for landing, because if we think about it, it may feel from a conditioning standpoint challenging to go up a step, but from a landing standpoint, the thing that you're landing on is coming up to meet you, so you're actually not going to land as hard. So doing progressive step ups at progressive heights, coming down with control, but worrying just more on how you get up onto a step, try to work on posture, and work on light landings of the foot making initial contact with the step. Step ups will obviously be easier than box jumps where 2 feet come off the ground and have to land. But a box jump moving up onto a step or a box is much easier from a landing perspective than actually coming down off the box and then coming back up. All right, so we start with actually jumping up onto boxes before we do even any type of bounding or jumping in place. And that would come next, where we're looking at just like gradual hops in place, bigger hops to jumps in place, maybe even running in place. So I like to think of it as 2-footed hops are a little easier to control, especially if you have a unilateral ankle injury. The other ankle can take a little bit of the load. And then we can move to running in place, where it's basically an alternating foot coming off the ground, pulling the feet off the ground in an alternating fashion, trying to see how your reciprocal motion of your arms and legs are working. How's the landing feel in place? And then that can go into some type of unilateral hopping, where we're just hopping on one side over and over again on the, working up to the side that is injured, starting with small hops in place and then bigger hops, and then multi-directional, being able to jump forward and back, side to side, all different directions. In pain and certainly impact control becomes one of the things to look at. So even if the pain isn't there, I'm not going to progress people if they just have no ability to control their landing. So what you're looking for with a controlled landing is less time spent on the ground before going up into your next hop. Or we can look at it as doing some type of drop jump, where you jump, land, and move into a direction that you want to, but you don't want to be spending a lot of time. You don't want to make a lot of noise when you land. And there certainly should be some type of natural way of controlling. So again, this is where the balance challenge will come in with the landing. So if I land from a higher jump and I just land straight down, and I don't have this idea that maybe I need to hinge at my hips when I land, or sometimes if I'm moving forward and I'm losing my balance and I just naturally flow into a step. Well, if I've trained that more statically at first, when I start to get a little bit more dynamic with jumping and landing, my body's going to naturally flow into the most optimal landing position, hopefully, which will limit, the amount of impact that the injured tissue has to take as it's going through the ground. All right, so you're hopping, you're jumping, you're running. That should be a nice extension of what you did with your balance work. And the same thing with cutting and lateral agility. So, it's really a similar process with cutting and lateral agility. It's just the starting position is a little bit different. So you work on something called a lateral stance early on, where you basically teach the body statically how to shift your weight to one side more than the other. And then you can alternate that movement side to side. So it sort of looks like side lunging, but really, really taking some time to feel that weight is really being taken in the hip, through the lower extremity, even up into the core. So just trying to make the body feel the position more centrally. So when we do move, one will be more explosive if we move from our hips and our center a little bit more, but it'll also take load out of the ankle calf area as we start moving side to side. So once we just are able to hold the position and then shift side to side, we can add a small hop from side to side, landing in this lateral stance position. Then we can increase the distance of the hop. Then we can increase the speed of transition from one hop to the next. Before you know it, it looks like you're jumping back and forth, and then that can turn into side shuffling, change of direction drills, etc. All right, and then finally, return to sport. I mean, if you've gone through all of the drills that we've talked about, from walking to running to hopping to lateral cutting, I mean, you should have most of your arsenal for getting back to sport. However, it's still not sport. The difference between competition and non-competitive drilling, I think, is quite large. Anyone who's ever played sport. So even in the return to sport, the randomness of sport, we want to try to keep that non-competitive first as much as possible. So do that with just doing your normal drills of your sport and progressing the speed, progressing the duration of it gradually, and then getting into maybe some scrimmaging and practice where you can control the amount of time that you're doing the sport. I think that's really important. It's not always easy and practical within a sports setting, but being able to scrimmage at practice with teammates and being substituted for maybe after each play early on can be a really useful thing to get you to sense, what it feels like to get back into the action, but then be able to stop, sit down, recover, and just see how your body does in the recovery process before getting back out there, as opposed to just saying, okay, I'm going to play today, I'm going to play the whole game. Once the competitive juices start flowing, there's really not a lot of control. There's not a lot of assessment that can go on there. And I don't think it should if you're going to really be out there playing competitively. So really having a good process for being with your coaches and teammates and talking to them about, maybe purposely limiting the duration of what looks like competitive play before you actually get back and play against, opponents that you want to beat. I think that's really important, not always practical, but that's how I would look at it. So hopefully that was useful. Again, this is a very common injury. One of the most common injury I've ever experienced in my life. When I played basketball growing up, I'd say I'd have like one or two anterior talofibular ligament sprains per year. And then when I stopped playing basketball, funny enough, I didn't get too many or any. But it's very common, and it common to the point where when you're a basketball player and you don't really think of it as that big of a deal. It's uncomfortable for a couple of days, but you're really just wondering how quickly can you get back into the game. So things I've learned being a therapist is, one, that not everybody has that mentality about spraining their ankle, right? So to some people, spraining their ankle can be a much more chronic problem. And then for athletes, just because it doesn't hurt doesn't mean you shouldn't work on it, or you shouldn't be mindful of the fact that you had an injury to your ankle. So I think a lot of times with athletes, just getting back to play is, I can play, doesn't hurt anymore, but you forget that, all right, you did cause some damage to the tissue of your ankle. So you may have lost some range of motion in your ankle. You may have lost some balance in your ankle. You might have lost some coordination there. So having a plan for some of the things I discussed, whether you have ankle pain or you have an acute ankle injury or not, is quite useful. And I'll put this in the show notes of showing some things to work on: the excursion of balance, how to look at gait, how to look at progressing, running and cutting. Because if there is an injury, you can always, just turn the volume down using some of these regressions. But it also can be an assessment, even if you're not having an acute injury, to see how challenged you might be from a balance and coordination standpoint with some of this stuff, and that's not uncommon, even if you're a very high level athlete. So hopefully this is useful, whether you've just had an acute ankle injury like my friend George, or if you're, just an athlete or someone who's trying to stay athletic as they age, like yours truly here, that you have some type of assessment process for these functional sport related movements. And I think one of the things I found is being an athlete in the past, but no longer being an athlete, there's so much value in knowing these athletic movements, but what you have to be able to do is break them down and make them a little bit more digestible for as your body changes, as your life changes, that you can still keep your athleticism. But if you only look at it as it's done in the throes of competition, there's no control over it. And as you start to injure things, you won't know what to do and you'll just be done. You'll just feel like I'm too old to do this thing. But when you start to break some of these movements down, it's very easy to stay in the game because you can just turn the volume down. You can make it part of your training in a non-competitive environment. And you could feel young and athletic, and you might even be able to improve some things from an athletic perspective that you never even thought of because you just sort of took it for granted that you were able to do it. And it was, the intention was really the game, where now the intention could be the quality of movement, and you can actually feel sharper with some of your movements than you ever have before. So take a look at, what I put in the show notes. And if you have any questions, or if you feel like you need to see something that I didn't put in the show notes, certainly send me a comment and I'll do another video. I'll see you next time.